You're listening to the Physio Matters podcast in association with rehabmypatient.com, and this is session 82. Welcome back to the Physio Matters podcast. I'm still Jack Chew, and I'm keeping these as brief at the moment because we've got a Chewing It Over show, which is weekdays, 12:30 till 1 o'clock every weekday. So, therefore, I get a chance to update you on all sorts of news, and we can clip that and share it with you. And so it stops these being 5 minutes long, which some of you have been enjoying, but some of you have been frustrated by, and so we can keep Physio Matters as being a clinical show. So, without further ado, I want to thank the guest of our last episode, which has gone it's been really popular, especially for provoking discussion and debate in and around structuralism. It's an orthopedic surgeon, and so we sort of talked about structure and the relevance and prevalence of it, especially with regards to knee surgery. That was Jonathan Bell. So thanks, Jonathan, for joining us. It's been really popular, and we're still getting your feedback, so please keep that coming. Today, I'm going to be talking to Michelle Angus. You might recognise her name from a chat she had with Tom Jessen and Rob Tyre on the back of Therapy Live, where they were talking about serious pathology. She's a consultant physio at Salford Royal Hospital. And so when we talk about back pain, which comes up in the podcast quite a lot, it's often in that context whereby we're talking about screening of serious pathology, etc. But rarely do we get stuck into how those patients should be managed, how that might vary depending on the context in which you see them in sort of sport, in an emergency department, and not get stuck in the weeds of red flags, of which we've covered at length. And so it was great to go through things with Michelle as to what might be advised, what might be, the use of medication, advice might be given, what do's and don'ts are, and things like that. So it was fantastic to go through that with her, and I hope you enjoy this podcast. We've got lots of news at the moment. I've got really exciting stuff coming up to share with you. I won't say too much about it here, but do check out Chewing It Over if you want to find more about that. And also just keep an eye out on the social media feeds. That tends to be the best thing, especially if you're interested in attending the Therapy Live events, as well as other things we've got going on. MSKR have a birthday event on the 23rd of October, which I'll be announcing shortly. And so please do keep an eye out on that. That's going to be about APP and FCP and all things acronyms, and talking about some of the opportunities and challenges in the very MSKR way as they launch their Thinking in Public series. So do check those out. Again, social media and on Eventbrite for Therapy Live Sport, which is the 7th of November, and MSKR's birthday event, which is a free evening webinar event, again, on the 23rd of October. So thanks a lot, and I'll see you at the other side of this interview with Michelle Angus. Delighted to be here today with Michelle Angus. We're going to be talking about acute low back pain, something that's been long requested, and we've been looking for the perfect person to sort of talk us through this. Not in a red flag sense, although of course we'll be appropriately visiting that a little bit at the start of the podcast, but this is more to do with when those things have been appropriately not ruled out, but associated to not be as important to a case. What is the ideal management? Now, Michelle will introduce herself in a second, but has lots of experience at the front line in various different capacities, but most recently in emergency departments, and not far from me as well in North Manchester. So welcome to the show, Michelle. Would you like to introduce yourself to the listeners?
Yeah, so I'm a consultant physio at Salford Royal. I work in the emergency department. I lead a team of advanced practitioners within the emergency department and acute orthopedics, but I work for the spinal service within that department. So see quite a lot of back pains at the minute.
Yeah, and I imagine lots of back pain. You've been in MSK a long time, so back pain in various different contexts as well.
Yeah, absolutely. I've qualified in '96, so unfortunately I'm one that is described as a dinosaur. But yeah, I've been around a long time in sport, private practice, MSK outpatients, that type of thing. So back pain, as I'm sure you know, Jack, follows us all throughout our career. So yeah, lots of patient examples, hopefully.
Yeah, well, absolutely. Well, I'm not a fan of the dinosaur slur, but when it is used, it's suggested people that aren't adapting quick enough. And I doubt that's you from what I've been reading and learning about in preparation for this interview. And so acute low back pain. One of the things that I've heard recently is that there's an accusation that it's sort of overplayed, but how prevalent is it? What is the sort of landscape in an emergency department as to how often it presents there? Not the only place, of course, it presents, but let's just get an example of how that is a good perception of what someone perceiving it to be a social emergency.
Yeah, I think we're possibly not the same as a normal district general hospital because we're a tertiary spinal referral centre. So there's a lot out there in social media and things like that to come to us because you'll see a spinal surgeon, which obviously when you attend the emergency department, you don't see a spinal surgeon. No. Chances are you'll see a junior ED doc or me or one of our team. But we see between 10 and 15 back pain presentations per day. So a lot of patients. Now that could vary. So that comes off the hospital coding. So that might not necessarily be an MSK back pain. It could be something else that's caused the back pain, an aortic aneurysm, but if they've been logged in by the receptionist as a back pain, that's what it's coded as. So we don't know our exact numbers of MSK back pain, but we know that we see a fair few patients who come in back pain and struggling, and that's why they come to ED.
And often as a patient, it's MSK back pain until proven otherwise in many ways because of the social knowledge of back pain, and it's rarely known to be something that could be more serious and medical. It's one of the things that people bugger along with for longer than they should do for those reasons. So it's actually probably appropriate to use the stats by coding.
I guess so, yeah. I mean, that's when I first started in ED, that I remember Pete Driscoll, who was the consultant at the time, who's retired now, and he said to me, what you need to do, Michelle, is flip your mindset. But as a physio, everything's the lowest common denominator until proven otherwise. In ED, it's the worst case scenario, and you start there and work backwards. And, he told me that probably 15 years ago, and I've worked with that mantra since then, really.
Absolutely. And that is a really valuable thing, it's one of the reasons why I think some advanced practice principles, as they're sometimes thought of in physio, should be taught even at undergraduate, because that systems thinking mindset of where you are, the sigh of relief, even for what might be a serious and very painful MSK condition. But A&E docs that have taught me over years in various different capacities have said that you're constantly ruling things out, and then you're relieved when to find that it might be still very painful, and the presentation still as was, but you've ruled out various other systems and stuff. So now, what sort of time do you feel you have on average with someone that's presenting if you're the first point of contact?
It varies completely what they're coming with, really. So from obviously, I think you'd be living under a rock if you don't know the pressures ED are under at the minute. But there's no. I wouldn't pick up my next patient until I'm ready to pick up the next patient. Yeah. So although I will feel the pressure of the department. So if it's busy, then absolutely I feel that pressure, and I want to try and speed up. But if I need to spend time with somebody, I'm quite lucky in that my consultants will absolutely not move me on until I'm ready to, because I manage my own caseload. That said, I can see 20, 25 patients in a session, not all back pains, some simple finger stuff and other more exciting stuff, really. I think going down the spinal route, I get excited when somebody comes in with a finger chopped off. But you've got as long as you need, and that's the luxury, really. We do have standards and targets, and people should be seen and sorted within 4 hours within the emergency department. But if I've got somebody who I want to do bloods on, do something with, and then review them in 4 or 5 hours, that I can admit them to have that done, and then they can still be my responsibility. So we're very fortunate in the system that we've got, and I appreciate that people out there in practices, in clinics, are far less fortunate than I am in those environments.
What's the spinal equivalent of someone coming in then with? I want to talk about typical presentation in a sense, right? So. Yeah. And again, we're now past the red flags, but we don't know this yet. But what are their behaviours, their functions? What is it that typically brings someone with acute back pain? And in this instance, we don't just have to talk about ED, but let's just talk about the classic behaviours of an acute low back pain patient.
So I think it varies from sort of one extreme to the other. So you've got your person who has been in the gym, possibly overdone it, or possibly done something and felt a pull and like muscular type symptoms, and you've got that end of the spectrum, and they do come to ED because I think there's a perception that because it's your spine, it's different to a sprained ankle. It's a bit more serious and a bit more worrying. So you sort of got that end of the spectrum to the other end of your patients with absolutely acute, rock solid, complete shift, probably discogenic, raging leg pain, that are presenting who may ring an ambulance to get there and need Entonox or IV morphine in the ambulance. And again, that could be at the gym the same, but you've got your sort of two extremes and everything in between that we get, really.
Is it more often that there's been an incident or a moment in which it's been not necessarily always sudden, immediate onset, but there's actually something that's an attributable movement or incident rather than it being something that's been more insidious or emergent?
I think the insidious ones possibly don't come to ED as much. We see them in physio, absolutely, you know, seen lots of them in physio in other areas. But I don't know if it's just that the patients are in agony and are trying to attribute it to something, and that something may not be where it started. But I think the acute ones, so I'm not talking the chronics, the acute ones that come to ED have usually, they attribute it to something, some sort of activity or something that has happened. Or they've woke up with it, you get that, but there's a change. And they don't,
Yeah.
so it's not a gradual, this has got worse over the last few months. You get some of those, but generally this has changed. So I've come to the emergency department because things are different.
Yeah, and obviously when I'm thinking about the insidious, I'm sort of even meaning just a few days rather than months. But it's interesting because I think that the way in which people perceive and attribute to an incident, and therefore it's almost a totally understandable instinct to then, like Joe Bloggs is a structuralist, and I can't blame them for it. Not just because of the way in which we've come to understand the body until relatively recently in time, but also just in a sense of perception when we become injured. It's just something that the locality and thinking, what is it? What else is there in a basic anatomical sense? It's totally instinctive. As someone that unfortunately has experienced more pain than I'd have liked in various different body parts. But in this instance, what is the typical sort of way? Are they often? I suppose I want to try and see if I can get some statistics in away from you. There's lay statistics or percentages in a sense that are they typically your patients crawling in, hobbling in on a stretcher, or is there a large amount that are coming in that to look at you'd be thinking they'd be all right, but they're describing symptoms of a high intensity of course, which is, you know, completely reasonable and believable. Like, I'm just meaning, like, what's their behavior or their function?
Again, it varies. So you will probably get one or two a day that are ambulance come in and on a stretcher. And do you know what, Jack? You get them that come in on their Entonox. They've had IV morphine by the crew. They come in, they get pat slided across to a trolley, and the nurses are, you know, putting them in a gown, and it's absolutely struggling. And then I go in and they say, "Oh, I need a wee. Can you walk there?" "Oh, yeah, probably." So you get that, and it's fascinating, really, the psyche, what patients think about these kind of things. And I think there's an A&E mindset that's very different to a physio mindset, in that, you know, they get put on a trolley, they get put in a gown, whereas actually if I can do my neurological examination in standing against gravity, I might well check my motor function in standing against gravity, because it's functional, and I can, you know, I can check that in a better position. And some of them can't lie down, so some of the muscle spasms, absolutely getting on and off the bed is a problem for them. Sitting with a neuropathic pain is often a problem for them, so they may well have come in. Some of them put the chair, you know, in the car, they've put the passenger chair completely flat to allow their partner to bring them in, and they can walk, and they say, "I feel a fraud because I can walk round, but I can't sit down." And you have to sort of explain as to, yeah, absolutely. So you get those ones who are like, "I'm really sorry, I do feel like a bit of a fraud being here, but I can't do this, and I can't cope not being able to sit down."
Absolutely. Now, in what I think is, I'm always torn over, because it does seem really individually specific and the context is super relevant, and we know the complex biopsychosocial phenomena that surround every individual case. But how much do you feel that the patient sometimes, especially once they've pulled that trigger, say they've called an ambulance or someone's called an ambulance for them, and how much do you think that the patient is sometimes complying within a system of emergency, so they then become passive to it until you then say, well, if you need a wee, could you go? You might be the first person that's inferred that they should do anything active, or how much do you think it is that actually that situation has only complied with their needs? Do you know, because there's a massive difference between the system complying to them and them complying with the system. Do you have an opinion on that?
Yeah, it's a bit like your PJ paralysis stuff, isn't it? Once they're in hospital, they put the pajamas on and they don't ever get dressed anymore, and it's just absolute nonsense, isn't it? You know, if somebody can function, maintain their function wherever possible. We tend to, anybody who's got a hint of anything, leg, neuropathic, anything like that, we do a lot of bladder scans. So we bladder scan most of our back pains that have got a hint. And you know, you've only need a little bit of muscle spasm for the pelvic floor to spasm and for you to have some bladder dysfunction. Absolutely you do. So we do a lot of bladder scanning to make sure that these patients can void properly. So I will always try and get them to a toilet to do that rather than lay on the bed. And you can come into, you know, a nurse will automatically, some nurses will automatically just give them a bottle. And I'm not a man, but I wouldn't be able to wee on a bedpan. I know that for sure. And I don't know how hard it is weeing in a bottle, but on your back, but I'm sure it's not an easy thing to do.
Well, you've immediately got the sort of dignity compromise straight out the gates. You know, that is an obvious, the bodily functions thing complies you with a sort of medicalization really quickly. And I think it's sort of relevant that, as I said, you might have been the first person to even infer that they might be safe to do something actively. But what you and I think, have got some instincts of a similar flavour there with regards to it being sometimes a bit on the coddling side, which is going to be deleterious to function. Sometimes people get, I think it's the instinct of compassion that's got them there. Are you and I, in this instance, sounding cold, and that actually sometimes that can get, we can be accused, not just on this show, and I don't know, we've not worked together, of course, and maybe I don't want to tar you with my brush here, but I'm just thinking that sometimes that perception is that they're doing that as a means of being compassionate, and sometimes done poorly, asserting some level of functional assessment even, or inferring that, and their eyes pop out of their head when you suggest that they roll onto their side, because they just think, what, are you some sort of savage? I'm in agony, you should be carrying me there. Is it, what's your sort of take on that, and how do we make sure we come across as not cold-hearted?
I think, yeah, you're dead right. I probably do come across as cold. And it's not just your backs. When it's like when you're in physio and a junior asks you to go and assess this patient's knee, and because it won't move, and it's like, you've just not moved it. It's, you know, actually they've got full range of movement. You've just not took it through the full range of movement. And yeah, absolutely. And I do tend to, quite early in my consultation, talk to the patient and say, look, I'm not going to get you pain free. I put that on the table quite early doors, because I want their expectations of that journey to be true. And I don't want them thinking that they are going to skip out of that department absolutely pain free, because I know that's not going to happen, no matter what they've been given coming in. So I do like to explain why I'm doing things, but also explain to the patient that the pathway that they may well go down. And, you know, these often patients are in pain for a little while, but it's not going to do any harm. And it's that hurt equals harm thing that we come back to. And I appreciate this is painful, but you've been in an ambulance, you've been on a trolley, you've potentially been lay on the floor for hours at home because something happened and you couldn't get up. So you've now not moved for 8 hours. It's going to bloody hurt when you try and move. No matter what I do, it is going to hurt. And it's explains to them, I understand it's going to hurt, but I absolutely, it's not going to make your pathology any worse. It's not going to make your journey any worse. But what will make it worse is lying flat for weeks on end. We know that, the longer you stay still for, the harder it's going to be to move. So although you might think I'm cold, and you might think that I'm not doing the right thing, I'm doing this in your best interest, because the longer we leave it, the harder it's going to be.
When it comes to managing those expectations and trying to get people, because I think you're right, the sooner you can get that in, the better, especially once you're in a situation where you're feeling confident that you're not going to be describing at least a medical pathology or a process.
Yeah.
You were going through this as being having appropriately ruled out, for want of a better term, or we're not prioritizing a red flag pathology or other more specific medical pathology. I agree, of course, with what you've said, but it's just that how do we manage the expectation appropriately so that then we're not the people that, when it is uncovered, that that it doesn't move in the direction that we'd like it to. How do you cover your tracks in an appropriate way where you're assuring them that the likelihood is that this is the direction of travel that we're expecting, that we're not the people that say, well, lady in A&E said, I'd be fine by now, and this is what she's missed. This is which of course we've all been there, because it's not an exact science. But do you have any styles of language or top tips where we can make sure that I'm not meaning covering our tracks legally, I'm just meaning with the patient, so that they understand that part of the expectation is that it's not a guarantee that what we're describing will be the trajectory.
Yeah, I think you're dead right, and I think I do always say sort of to the team because I basically have sort of an on-call phone as well for ED clinicians for our team, but for also the CAT service and other people, and I do always say to people, look, you're never going to get questioned for that patient. You do a scan and they have nothing wrong with them, but the first one you don't scan, you're going to get quite a lot of questions about if there is something wrong with them. So I appreciate we've got a duty of our imaging and how much imaging we're using and doing that appropriately, and I get all that. But in ED, we're dead lucky. I've got access to bloods, X-ray, CT, MR, a senior decision maker, consultant spinal surgeon. I've got all the help that I could possibly need, and I appreciate that in a physio clinic or an FCP clinic, you don't have any of that, and you've got to make a decision yourself. But I do think that if I'm worried, I will do something to rule out what I'm worried about. And that might not be today. So I might well say, okay, I think that you potentially have got X, be that, I guess, probably, a nerve root problem. So you've got 3 out of 5 motor function. That might well need decompressing at some point. And it varies from surgeon to surgeon. So some of our surgeons will do that straight away. 3 out of 5 or less, they will absolutely act on very, very quickly as a sort of one step down from cord recliner. Some of them want to leave it 6 weeks, see if it reabsorbs and gets better. So,
making me sweat when I think back now.
Well, yeah. So, and that varies depending on who's on call. But my duty is to image that patient and get them to that's whoever's making that call. That's never going to be my call to make, how quickly they operate. But I don't want to delay that patient's pathway at all by not acting on the symptoms that they've got.
Would you use things?
Sorry,
I didn't mean to interrupt there. Would you? Because there's a pro and a con to saying to them, this is the plan, this is the trajectory that I'm expecting. If it doesn't turn a corner, or it's not moving in the right direction, or we're not a certain amount better by this point, then that's when I think a scan will be indicated. And that, if you're as particular as that, because I used to do that, and then I just took a bit of an edge off that and wasn't as particular over time frame or by your next appointment, or because sometimes it just means that they aspire to, if they're in a situation of which they're interested in that investigation, it's actually moving in the right direction, but they think I'd feel more reassured by that. I'd almost want to preempt that conversation. I feel like I hope I've been there before and justified imaging or not at that point. But I stopped putting a particular time frame on it because it felt like they were then obliging the answer to get an outcome that they needed or felt that they needed or wanted. So I took that off. But then I've been accused since doing that sometimes of them being a bit too, that then becomes almost too open-ended or too vague. What's your sort of position on that?
I rarely say that if you've not met this, you will need imaging, because I can't very well get annoyed with people saying go to A&E because they need to do a scan to rule out cord recliner. For me then to send people to a interface service to say you must scan this person, that would be hypocritical of me. So I rarely say you will need imaging if this hasn't happened. But what I do say is if things are not improving in the next sort of 1 to 2 weeks, I would expect, with you taking appropriate analgesia, keeping moving, keeping walking, not taking yourself to bed, I'd expect things to at least start to improve. We're quite lucky. Most areas around Greater Manchester now have self-referral to physio, and I go down that route really. If things are not improving, you need to get yourself into the physio system, and that's where you'll then get your next assessment and plan as to where you're going. If it's our physios, if they're worried, they'll ring me and I can go and see the patient. If they're most places again can escalate to the interface services if from physio and get imaging that way if they need to. But yeah, I think it'd be hypocritical of me to say this service should be scanning you at 6 weeks if you're not better, and then moan about people sending patients to A&E.
Yeah, no, but it's almost that all of our guidance there and our ethics and morals are all based on a system, not a utopian one, but something that we hope is going to then be compliant with sort of sensible decision making. And that as soon as it goes outside of your room, your department, your hospital, etc., it starts to feel more ambitious because of the variety of care that we know gets delivered. But I won't bang that drum. It's one of my favorite drums, but I won't go there now. Muscle tone. I want to sort of talk a bit about that in terms of muscle spasm, etc., for a few different reasons. But I definitely want to detach it where possible, not completely from ED, but kind of that these presentations, be that in a sporting context, in a FCP, primary care, private practice. That is often it can be a symptom of a protective tone around a complex and sometimes even fairly unstable fracture. Let's even say outside of neurology now. So it's not stable enough for it to be given us those clues on a large spondy or something. But I'm just meaning that we know it can be that, but we also know that can be one of the biggest masquerades that exist, whereby this is a sprain, a strain, or whatever we want to call it, and it's actually not as serious as it's behaving or perceived. How are you teasing that out, and how often, I suppose, do you feel it is something that's representative of seriousness and a sensible defensive mechanism of the body, and how often is it misleading?
I think I guess it depends on the context and depends on the patient, and it depends on what's happened as to how you're going to sort of image that patient. So, I mean, I guess, for example, that within sort of sport, I remember one of my athletes in hyperextension injury, young girl, tall girl, absolute agony, muscle spasm, really, really struggling. And we imaged her straight away because, if she had a pars fracture, that's going to change what we do. I remember distinctly because she absolutely I couldn't even really get her walking with all my tools and tricks and everything. I was really struggling, and all she had was some inflammation in a facet joint. That was it. But the hyperextension had for whatever reason caused the facet to react, and she had an effusion within her facet joint. And I'm not saying that every patient needs interventional things doing. Absolutely, that's not my take. But equally, we wanted to get her back playing. We were in the holding camp for the Olympics at the time, and so she had an injection into that facet joint, much like you would an inflamed knee, and got back on the playing within a couple of days. Her muscle spasm was then the limitation that I could as a physio get rid of that then to get her going and get her moving. But there was an underlying pathology that caused that. I do think that it's really hard, isn't it? Because mechanical back pain is absolutely what's drilled into us. And I think it's wrong to give the patients sometimes it is wrong to give a diagnosis of you've got this. But I do think that unless you've done a specific action in a gym, there's usually something that's caused those muscles to go into spasm. Muscles don't really spasm for no reason, do they, without something underlying that's caused that, or some kind of action that's caused that. I could be wrong, but I do think most of them have got something going on.
No, well, that's one of the reasons I want to get your take really as to that complexity of causation. I agree in that when you've got something like the extension example, such a great one, especially because the context around that athlete, meaning that they are just that's one of your primary your rationale for why that might well be a spondy and potentially a high grade spondy in something that the consequences, not just immediate but also down the line for that athlete, is huge. you've also got these. So I'd say Joe Bloggs. Let's make Joe Bloggs a builder, and he's
Yeah.
picking up a bag of cement in a flex, slightly rotated position. It's not high load for him. Carries 5 of these at once often, but it's something that he's just made that sort of classic lift with twist. And he's then got, again, we're not giving him any leg symptoms now, but he's got then this muscle spasm. So it's something that there's an incident preceding it,
Yeah.
but there's not a high grade incident that would be indicative of more serious pathology, such as the athlete that you described. They're then presenting, and let's open up the context of which they're presenting beyond just ED, but they're presenting to private practice, they're presenting to FCP. They might, let's imagine there's a triage service often in many clinics, especially in around the Manchester region increasingly, following your services, and East Lancs are doing a great job even in collecting data in this direction. They're presenting to something like that, lots of muscle spasm, no leg symptoms again. What that's sort of in this in between where there is an incident, you can make an argument that there could be some sort of relevant tissue characteristics that are then being protected, discogenic or otherwise. But are we how are we going about managing that patient?
I think if you're in a clinic then and you've got no indication to image that patient, no matter what's the underlying pathology is, your treatment is going to be the same, isn't it? Getting them going, getting them moving. We've had them because as soon as you get a hint of bladder dysfunction, they come to us in ED. They end up with us and they get a scan. That's the bottom line is for whatever reason. And the pelvic floor is part of that cylinder, isn't it? That goes into spasm.
Are you meaning a bladder
Absolutely.
scan there? Are you meaning they're getting an MR?
No, so an MR, a lot of people getting that. So, if you can't empty your bladder, chances are most people are gonna scan you. But the pelvic floor is part of that cylinder, isn't it, with your muscle spasm? So you've got spasm of your erector spinae, you're gonna have some pelvic floor dysfunction, quite likely. And a bit like your example, I remember a weightlifter had been no heavier weight than normal. Back went. Well, that's a classic patient term. Don't know where it's gone, but it's gone. Yeah. And pelvic floor's not, got spasm, so much so the pelvic floor's in spasm, so ends up getting an MR scan. And on those kind of patients, often what we see is a little annular tear. So, we're imaging them. That imaging is not going to change the management of that patient by any stretch of the imagination. But often there's a little tear in the disc. It's not there's no bulge, but what you can see is the outer fibers. There's a little tear, and that's caused all the secondary symptoms. Now in a clinic, that scan isn't going to change what you do. So, if I scan somebody and they've got a little annular tear, I'm not still going to do exactly the same treatment. I'm going to get them moving. I'm going to advise them, this should get better. This is what we need to do to try and get it better. I'm going to give them pain relief. If they need loads of pain relief, I'll give them loads of pain relief because I want them to move. But it's not going to change. So I think if you see them in clinic, you don't need to image these people unless there is, obviously, you're worried about something more serious. What you need to do is use your basic stuff to get them going, get them moving, and try and facilitate that normal function. I think early on, normal function is the most important thing, and educating them as to why that's really important. I worry about chronicity with these patients, and I worry that if they don't get that advice or they go away and go to bed, and then they're the ones that are going to be the revolving door patients. I just hope that if we get it right, we can stop that with these people.
Just in and around the weightlifter that's then had this spasm, and I called it a builder. We're talking about it as a fairly stereotypical case, and the spasm in this instance, you're saying that if they happen to have had a scan, not necessarily for their symptoms, but because they seem to have had some bladder retention that we now know is sort of neuromuscular, they've had this scan, and you feel that there's a potentially you were describing potentially causal annular tear that predisposes the muscle tension. I want to know as to if you are, let's say they've not had a scan, and put yourself maybe in a different context to ED for a second. What's your lingo there? Are you allowing them to associate that muscle spasm to a protection of a tissue-based pathology, or are you not mentioning it? And that's without them having a scan first.
I think I tend to, general spiel is that there's a lot of structures around the spine. There's the disc, there's the joints, there's muscles, there's ligaments, there's a lot of structures, and I am not always going to know exactly which structure at this point, when you're in agony and you can't move, is necessarily at fault. But what I do know is that none of those structures are going to be harmed by you moving. And it's about that sort of perception. So I am quite vague with them about what could be going on. If they dig and they want more information, then I'll get the model out and I'll show them all the structures and that type of thing. But generally speaking, I am, as much as I'm not a fan of mechanical back pain, I am quite vague with them as to the actual putting my finger on that point. At that point, really. But what I do know is that there is nothing that I'm going to cause more harm by getting you going and getting you moving. I talk about the fire. We've talked about car alarms, haven't we? But the fire, you touch a fire, it's hot, so you pull your hand away, and that's what your muscles are doing. The fire was hot, and so they've reacted. They've done that spasm reaction, and actually now we need to switch them off a little bit to get to the bottom of why the fire was hot.
So then the other side of it was that they've had a scan. Let's say there's a couple of reasons they could have had it. One is the justified reason that you gave with regards to the bladder, but there's also the opportunity through particularly other contexts where they've then had a scan that probably wasn't indicated clinically, but we know that it's an imperfect world, as we talked about earlier. So they've had a scan, and you have noticed, and I know this isn't changing the treatment and the care that you're going to deliver, but I'm just interested in that patient advice piece, because now you've actually got something that, instead of speculating, saying here's a number of structures, it could be a number of structures, because I recognize that mantra to my own, and also I think is a sensible one. Number of structures that could be contributing to these symptoms. However, they're not relevant. The tissue isn't relevant to the symptom protection. The spasm isn't there. It's not something that's going to do any further damage. Got you. However, once you know differently, right, and you've got this scan and say a report that might indicate a tissue injury that we're suggesting might be contributing or even causal to the muscle spasm, are you then going to risk giving that detail like you would an ankle, where you're saying, well, we've got some fibers of your ligament that have been ruptured, however it's not something that's going to need, it's going to heal well, you're otherwise healthy, that sort of thing? Are you doing that at the spine, or are you trying to almost keep that information from the patient?
Yeah, I do. It's difficult, isn't it? Because the National Back Pain Pathway talks about imaging being harmful, and you're causing harm by doing an MR scan. I don't think the MR scan's causing harm. What's causing harm is the people not understanding the report that are telling the patient. You've got whatever degenerative changes, or frightening the patient, or giving them a copy of a report that has got lots of long wording, modic changes, and that the patient goes and Googles and absolutely panics. So I don't think the MR scan was harmful, but I think that how you then explain that. So yeah, if there's something on the scan, I explain it, but I explain it hopefully in an appropriate way. I never ever copy and paste a scan report into a patient's discharge details or letter, and you see that a lot, that patients will just have a copy of a scan report that they don't understand.
Yeah, and they've been putting it into Google, haven't they, line by line?
Yeah, and I pick the relevant bits to them and absolutely write it down for them, but in a way that's sort of understandable. So yeah, if there's an annular tear, I'll tell them that, because that's what's in their scan. They've got a right to know what it's shown. But it's with that caveat that, look, this doesn't mean you're going to have chronic back pain. This doesn't mean that it's going to cause you long-term problems. This is what we're going to do about it. We're going to set you on this pathway. And this is how we're going to make a difference. So yes, I would tell them. I would tell them if they've got degenerate changes. Absolutely, I would. But then I'll use the grey hair and wrinkles line, and it's
you put it into an age-related context as well.
Yeah.
What I wonder about with that, especially because it's their scan, it's their report. They're often wielding it. Therefore, to not talk about it, not tell them, is remiss. But then, despite best efforts, the mate that he goes to the gym with when he was doubled over, or my mate's building colleague, as these examples that we've been using. So, how's your back getting on? What went on there? Well, it's feeling a lot better, but I tore my disc. Their association to it is still going to be strong in that instance, isn't it? And if they hadn't have had that imaging, in this instance, we're describing imaging that we're both recognising shouldn't have really been done.
Yeah.
But it's just that I do understand that if it wasn't so unethical to keep things from patients, I can understand as to why people would try and move away from that, just so that there isn't that association to that being the problem. And therefore, 10 years on, I've had a bit of a dodgy back since I tore my disc.
Yeah.
And that association, that strong association, just seems to be more prevalent at the spine than it does at the, you sprain your ankle. It's very rare, although people might remember the first time they sprained their ankle as a kid or whatever, they rarely would say, since I tore the ligaments in my ankle there, that's why I've had a bad ankle, unless they have obviously chronic ankle instability. But I'm just meaning that there is this perception with the spine that we could probably do with erring on the side of non-tissue centric diagnoses. But it's a fine balance. I totally accept.
It is. I think there is, but equally, you get patients who haven't had a scan who tell you about a disc they slipped 6 months, 6 years ago, or so that's a patient sort of perception. So I don't think it's changes it particularly. I still hear surgeons talking about slip discs. It's
absolutely. Well, it went, didn't it? So it's like a hockey puck being squeezed out or something. As I hopefully baited well there, we're now into a real classic and typical presentation of which the advice and management is fairly general. Now, there are some specifics that you would then describe with them, based on what they've told you about what their hobbies, interests, family circumstances, whether they live up a bungalow or not, top flight of a block of flats without a lift. These things matter, and I'm not inferring that we wouldn't have some specificity of advice around that. But there is also this general package, the leaflet materials of bullet points that we would then dish out. Let's go through those then. In terms of how much to move, what's your typical advice on that?
I tend to say little and often. So I don't know if your listeners probably know about the National Back Pain Pathway and the work that Dermot Ferguson did up in the Northeast. With quite a lot of his videos were really, really good. I did speak to him yesterday actually and say, where have they gone? We need them back on. And the CSP stuff's really, really good. Adam Dobson's doing quite a lot of good work on patient information leaflets and early advice. But absolutely, it's patient specific, and it's little and often. You wouldn't want them going out walking for 10 hours up a massive mountain, but equally they need to know that it's safe to move. And it's those messages of the more you do normal functional things, the better. I think, one of my colleagues got, she had a back problem. I can't remember if she had radicular pain or not. Worked in orthopedics, so she worked in an orthopedic fracture clinic. She rang Vicky Dickens, my boss, and said, I can't get out of bed, I'm really struggling. And Vic's like, right, take some drugs, get up, get moving, get out, and get here tomorrow. She rang the orthopedic surgeon, who said, you get to bed, you look after yourself, don't try, we don't need you here, you just get yourself to bed, get some rest. Absolutely two completely contradicting a piece of advice, and unfortunately that's what these patients get. They come to us and we're telling them to get moving. It's safe to move, it's safe to go. You're not a doctor, love. My doctor says I've got to stay in bed. What do you know? So it's really hard, and I think that's why we as a population are still struggling with these patients, because I think it's still quite contradictory.
What about medication then? What's your typical spiel there?
So again, I'm lucky that I've got access to all sorts of different medications, and where I used to work when I worked in Bolton, we always used to use PR diclofenac, and IV paracetamol, and that was the one that actually worked quite well. We don't tend to use IV paracetamol much in Salford. They tend to go with morphine, unfortunately, or fortunately. And when I did my prescribing course, interestingly, it's cheaper than IV paracetamol. So you've got a bit of you've got a duty of care for the NHS and money and everything else as well. Jane Ashbrook's just done a systematic review on this. I don't know if you've seen it, really quite recent, at Manchester Met.
I've seen it, I've heard about it. Speaking to Jane soon, actually.
Oh yeah. So Jane's brilliant. She's doing, she's got quite an interest in acute back pain and ED attendances and that type of stuff. And her systematic review, the only thing that stood out as making a difference was NSAIDs, which is interesting. I think there's a perception with patients that if you can buy something over the counter, it's probably not very good. And patients want a prescription. They don't want to be told, get some paracetamol and brufen. But then you've got to understand that that's still, in the whole health economy, you know, that there's not a huge difference that I'm aware of between brufen and naproxen. You know, we used to use diclofenac before the heart stuff came out. There was that big paper that talked about cardiac stuff with the COX-2s, and so we stopped using COX-2s at that point. But I think, yeah, absolutely. So now, always I would give an NSAID or advise an NSAID, but the root of that, like I say, IM, PR seems to act quicker. But again, Jane's papers found not a great deal of evidence for the route of administration. Now, I think that's lack of studies as opposed to, you know, put hard evidence against. But in ED,
speed of action would matter more to you in your context of work, though, wouldn't it? To say private practice, the mechanism of delivery you were suggesting would be, you perceive as being relevant to speed of action, and I was saying that whilst, you know, obviously that's something that's good to attain, that would matter more in your context.
Yeah,
might do others, because you're wanting to move people along. Do you feel that that's relevant?
Yeah, absolutely. And I would send the majority of people home with oral drugs. I rarely give them anything different. But what we want to do, what I want to do is try and take the edge off their pain and show them that actually taking analgesia will help take the edge off their pain. Now, I'm only giving them that to allow them to move. I explain to them that the analgesia is not the treatment. The treatment is movement. We're never just giving analgesia. A bit like if you in physio, whether you do or don't do manual therapy, whether you do or don't use heat or anything like that, you know, that's not the treatment. That's the pain relieving modality to allow the patient to do the treatment, that is movement and exercise.
Sure. Yeah. Do you get much pushback? You know, I don't want to mask the pain. I'd rather know what was going on. A variety of different things where people perceive that there is some sort of merit in having some sort of accuracy, and how do you uncouple that?
Yeah, absolutely. You know, have you taken the pain relief today? No, because I wanted you to see how much pain I was in. So you're in agony. You've come to the emergency department, but you don't want to take any paracetamol. Obviously, I don't say it like that, but there's a tells you a little bit, doesn't it, about people that, and if they don't want to take it, that is absolutely fine. But what I tend to say to them is, if you don't want to take pain relief, that's your choice. Absolutely, that's your choice. I'm not going to force you to do that. But it's really important that you don't use pain as the reason you're not moving, because it's gonna be sore then if you're not taking any painkillers.
How much do you have to then get stuck into the pain not being an accurate representation of, say, damage severity, that sort of stuff then at that point?
I think when I've been in physio, absolutely go into that in quite a lot of detail. In ED, you've got to remember that patients retain very little of what you've said. Yeah. So there's quite a bit of work, medical work that the docs have done, saying that, you know, it can be as little as 2% of your consultation is retained by a patient in the emergency department. So although I'll talk about stuff, I rarely get hugely stuck in unless I've got a patient who's really, really reluctant. But I rarely get hugely stuck in. I tend to give them things to go away and resources, because I know that they're not going to retain a lot of the stuff that I've said to them.
That's relevant, isn't it? It's that if you're particular about what you need to do, and then also make sure that that's laced with appropriate reassurance, it might not need that next bit, which is why I'm so confidently reassuring you. Whereas in a calmer context in which they're at least going to retain, let's say, 4% rather than the 2%, in a physio department, then perhaps that is something that the seriousness of the context, etc., means that there's a bit more compatible with that justification, especially when that maybe is down the line of an ED consultation, it feels like that might be an appropriate way to explain as to, well, it's because this pain isn't representative of the seriousness for these reasons, and using analogies and stuff. Alarm system analogies are my go-to still, admittedly, with regards to sort of sensitivity.
Car alarms going off too often.
Absolutely, yeah. Fire alarms and burnt toast is my favourite one. That's still my go-to.
Car alarms in the wind, I go for.
Really, it's similar. Yeah, I like that. What I would be interested in is that I often hear a defence, and these are by contemporary evidence-informed clinicians in private practice, particularly, whereby their rationale is for their behaviour of care that happens in that first consultation. Let's say over a 45-minute cash paid consultation. The behaviour of it is very similar up to the point in which then you're making the advice as to take medication, but not as a matter of treatment, but as a means of facilitating movement and confidence, and they're lacing it with appropriate reassurance. They're then giving them the parameters of when to come back, what to do, that sort of stuff. Be that to book them in at a particular interval or give them a sort of loose open appointment, see how you go, whatever it might be. And as I said, this is a well-reasoned ethical management. However, when it comes to the pain relief piece, they then would say that given the patient's choice, I've got these other pain relieving modalities available to me aside from the pharmaceutical ones. This is why I lay hands. And those that are being careful to then again lace that with, this is simply a means of just taking a bit of an edge off this muscle tone as a means of facilitating movement. And that is what I consider a decent justification for it, even though we probably think that there's some sequel to that, where the patient's making an association to the care. And I always say, no one ever comes into our practice thanking, when you say, how did you get better over, how did your last episode resolve? They never come in saying, tell you what, that paracetamol. Ooh. But they would do that sometimes with manipulation. And therefore, the inference of what it's done is sometimes more powerful even the words than you've used. So I do err on the side of caution, not typically a manual therapist, but I do understand that logic. I want to know from you, of seeing so much back pain of so many different flavors and contexts, what your take is on that rationale.
Yeah, I'd completely agree with you, Jack. I think it's really hard, isn't it? All the national guidelines now are taking away everything we've got to relieve pain as physios, and you know, the back pain stuff now, they've took all the neuropathics away. So we're down to little, and manual therapy. Maybe some people do believe, but I don't think as physios we ever did it thinking we were getting a bit of L5-S1 movement at that level. We were doing it to get a little bit of nociceptive reaction, to try and get a little bit of pain relief to allow them to function. And I think, you know, no matter where, everywhere, that's what we were trying to do. And I think this whole mentality of you must never touch a patient, or you must always do this. And the bottom line is there was a systematic review from Sweden this year looking at exercise therapy for acute low back pain, and there's pretty little evidence for that. So I completely agree that there's the evidence is poor, but anecdotally, if that allows that patient to move, you know, if you Skyping them, giving them some exercises, and they're in agony, are they going to do those exercises? But if you actually give them a bit of relief to allow them to do it, if that works better for you, I don't have a problem with that.
If it's nested within the reassurance frameworks that we're talking about, then it seems totally fair. What about that latter part that I was saying about sometimes the inference of, it might not even matter what you've said, but what they're inferring has happened with some manual treatment. Do you see any of that sequely? Do you get patients that have, because we're talking about acute, we can also talk about recurrent and acute on chronic type stuff. Do you see the patients that are then making association to whatever it might be in terms of care delivery before, that they're inferring as being curative before, and suggesting that you or someone needs to do that to sort them out?
Yeah, absolutely. You do. You see that, and you know, if it was, you just have to stop yourself from saying, well, if it cured you, what you're doing back. but yeah, absolutely. There is that, and their perception, but we know about how important the placebo effect is, and if they feel that that is what they need to get better, maybe they're not going to move on until they try that. I don't know. Certainly we don't do that at any treatment in ED, particularly other than advice and analgesia. But yeah, that we do see that quite a lot, I think.
If because that's where I think one of the stronger arguments for erring on the side of caution would be. So it's like not being a nihilist against some modalities, but recognizing that sometimes the association attached to them is going to be relevant. I would say that when you're describing, and I'd be surprised if it wasn't the case, but in ED, you're giving advice, you're encouraging movement, but not necessarily even couching it and calling it exercise as much as just trying to get someone back to scaled and relevant function for them. And encouragement, reassurance, analgesia. So let's just say that that's someone saying, well, NSAIDs or paracetamol, I'm not into that, or I'm not wanting pharmaceutical interventions, but you're describing something that can relieve pain. Typically, manipulation and massage is of a flavour that does suit me. Why wouldn't you be administering that
in ED? Because that's not what we're there to do. That's not the job particularly. That's
But that's what I'm meaning. Why wouldn't it be? I'm being awkward, devil's advocate. Okay. Of course, I'm not suggesting you should be. I understand why it's not. But under that logic, I think that I'm just meaning that why it's not the job, in part because time, convenience, medication is the go-to pain relief of the industry, isn't it? But should it be?
I don't know the answer to that really. Maybe not. But I think what we have with COVID, so our teams all advanced practitioners, and with COVID, we got some Band 5s. The COVID pot was quite a nice little pot, and so we got some newly qualified Band 5s who were absolutely fantastic, and they were doing a little bit with patients in ED, like so traditional MSK physio stuff. Like, so they would see an advanced practitioner, and then I wouldn't even given out any exercises. The Band 5s were doing it for us, and actually the patient feedback's been really, really good on that. I think, certainly now that the huge push is to stop people coming to ED, and we're even at the front door deflecting people to the physio department rather than the ED department's. Patients come to reception and get told, actually, do you want to come to ED, or do you want to go and go to physio in at this time, and you won't have to wait, you'll get seen at this time, you'll get, with the simple MSK stuff, not necessarily the back pains, but you'd be surprised what comes to ED. So at the minute, the huge push is to prevent the footfall of patients going to ED. It may well even be in the future that you have to ring 111 and get an appointment to go to ED. They may push it that far because we just cannot socially distance in the department.
Yeah, absolutely. Yeah, and that's one of the things that's relevant, and I swear it's only out of devil's advocacy that I asked that question, but I can conceive of the rationale underneath what we feel that the medications are doing, and we're not inferring that they are pharmacologically changing things in a causal way to it's symptom management essentially. So it's almost that in the future you could conceive of that. This is the advice. This is what you need to be doing. The treatment is movement. Well, the treatment is return to function without over associating this pain to be representative of its seriousness. And you need to find whatever it is that you can do to make that feel more comfortable. And then you typically go through this is where you correct me if I'm wrong, but you go through feel like heat suits you right now, then fine. Because people using heat and ice almost sometimes as an associated curative agent rather than a symptom relief. And so they sometimes think that there's a particular right or wrong there, and often it's, for me at least, you're giving that more generally, and it's up to you and whatever you feel. But I almost can think that there's, instead of it being here's your medication, it'd be here's a menu, what suits you, especially those that have been round the block a little bit. And you can conceive of a service. It's not a practical one, but it's one whereby they are choosing their own sort of flavour of pain relief and modality. And it's the system that stops us doing that. And I argue, many ways rightly so, especially on the public purse. But I therefore do have some sympathy for my private practice colleagues that have patients that have those expectations, and as long as it's appropriately caveated and couched as we're describing it, then there's good reason, and it's still good care, and if it stops them presenting to you, then that's a win.
Yeah, absolutely. And I think that's then the thing, isn't it? These patients potentially are not at the right place in ED and perhaps would be better with a private practice physio. Absolutely, that might be the pathway that would have been the best pathway for them, whatever, NHS physio, whoever. But yeah, I do agree that a lot of these patients, and hopefully as we become FCPs, we should be able to help with that and start to give them, I don't know, I guess it depends on what your FCP service involves, but I think, yeah, absolutely.
I'm not going to let us go there, because I know that the act of doing any treatment is the hot button topic on FCP, and so I agree with you, and I also agree with where you're going with that, in that it's sort of a sensible extension to that logic, is that if you have the skill set to do that, then if you're administering pain relief of a medical flavour, then why not others? I totally get it, but however, I accept that is a podcast in itself, and I'll be lynched. We'll be lynched. So instead, I'll move us on to the sort of progression as to what you would suggest to someone, that trajectory we talked about. So what sort of thing are you advising to people as to what thresholds you want them to meet for them to seek further help? If they hadn't met it or what have you, and we've both sounded like we've agreed that we'd be quite broad. We won't be it won't be arbitrary times. This amount of weeks, this amount, or this level of return or whatever. But what's sort of your typical advice for someone as you're waving them out the door?
So I always say that you need to, if things are not improving, the thing is, there's a patient perception around this as well. So if the patient thinks that they should be doing better by a week or 2 weeks, they may well need to seek that reassurance from whoever that may be. So what I don't want is them returning to ED unless obviously things change and they've got serious signs of serious pathology. So like I say, I'm dead lucky in that we've got self-referral to physio, and so that tends to be my go-to advice. If in the next week or two things are not improving, be that slight improvement or improving as you would like, then you need to get yourself referred in, and I give the responsibility back to the patient on that, rather than me doing a referral and them sort of moving things on. So I'm quite lucky in that we've got access to that. And most places I think now are moving to that, if they don't already sort of have that pathway.
Waiting matter there though, don't they, to that logic? So you're giving out like a business card that then explains as to how the self-referral service works. But if they then they're a few weeks in, they're not quite comfortable with the way that things are going, they then pull the trigger on the self-referral and then get given a appointment in 6 weeks, or they don't hear anything. And they're off work and all the other things. You'd hope that would expedite it if they had some sort of triage system. But that matters to the advice almost, doesn't it? Your knowledge of local systems and pathways, and even live waiting lists, I suppose.
Yeah, absolutely. And if things are, absolutely, that's a huge thing. I think the work thing's important as well, because every patient that as we know from work that was done years ago in the 90s, that the longer people are off work for, the less chance of them going back. And so we do a discharge summary for every patient that goes to the GP wherever they're from, and my advice to the GP is always 100% please consider early to return to work as soon as possible, and even on different duties, or because most of mine will self-cert for the first week, because that's the pathway. But yeah, absolutely, I definitely mention returning to work with every single patient.
Yeah, no, it's a really valid point. What sort of how do you manage the expectation in time frame without giving them sort of because you want to often give them bucket loads of reassurance, because we all know the cases that are in absolute agony and turn a corner, if not that day, then in a few days, and just can't believe that episode, and how painful it was, and they'll tell that war story forever. And it almost, they're a patient that changed their mind in perception of symptoms, and how representative of seriousness and damage it is. But then you also don't want to then assure them, oh, this will settle down pretty quickly, don't worry about it, for it to not do. And then 3 or 4 weeks in, even though that's still a timeline, let's say they're getting better at 5% a week, but then about 4 weeks in, it's not moving on as well as they'd like, and you reassured them of a timeline, your prognosis was sort of inaccurate. How do you manage that balance?
Well, to be honest, the honest truth there is I don't know, because they don't come back to us. We need to, and one of my team, Andy McDonough, is going to look into this, our return rate for back pains, because that's something we get flagged. So anybody who returns within 30 days gets flagged and their case gets reviewed. But our long-term return rates, we're not sure of, and we are going to do some work looking at that, because I think you're right, that's really important, because actually they come to ED, they see a physio on that day, and if they self-refer and they're put on a waiting list for 6 weeks, that's not what they want, is it? So yeah, I do see your point, and I do think that's services need to be reactive to the patient's needs here, and they need a reassessment. If that patient isn't doing as well as they would want to do, or they perceive that they feel they should be doing, they need to see someone quickly to get them on the right track.
Yeah, I think it's really interesting, because we need to join up the understanding, for the fact that you don't have a sort of answer on reflection of outcomes for that is a failure of measurement, isn't it? For us not joining systems up enough to be able to track that and have like a passport of care. However, just in terms of whilst you're not able to use the outcomes as part of informing your reasoning, that doesn't mean that you won't be doing something. So how do you personally find yourself managing the prognosis? What is your typical go-to? Are you therefore super vague and therefore just don't put timeframes on things as a matter of principle, or is it that you err on the side of caution and still give a time frame? What is sort of expectation management in terms of how long someone's asking you even explicitly, how long am I expecting to feel this way?
I do tend to tell them. So I say most people within the first sort of 48, 72 hours are starting to notice a bit of improvement. Now, that may not be the pathology. That may be the medication that I'm giving you that's starting to kick in and starting to make a difference, and you're taking that appropriately. So it might not mean that things are changing. If you get out, get moving, get going, I would hope that by 2 weeks you've gone over that hill and you're on your way back down. And the majority of problems settle within the first sort of, or get to a manageable amount within the first 6 weeks. If that's not the case, then we need to look at this in more detail, because what we don't want is for this to be a persistent problem or a long-term problem that's impacting on your life, your ability, your for the patient, that's really important, but also for the socioeconomic sort of side of back pain. We know that back pain is the biggest burden of disability in the environment. If we want to try and prevent that chronicity, so those are the timescales that I tell you. You've asked me this question about 4 times, so I've had to give you the times rather than be vague. But yeah, those are the timescales I tend to use with people. But absolutely, I don't ever say you'll need imaging if this happens, unless it's red flag stuff. And I don't ever say, you're going to be pain-free by 3 months. I wouldn't put that on them, but I'd say this is the trajectory I'd expect you to follow. If you're not following that, then you need to get help, and that help I need to tell you how to access that help.
Brilliant. Well, that was as gentle as I could ask the same question a few times. I thought, I'm glad I baited it out to you. But what I want to finish with, Michelle, so thank you so much as ever for your time. But I just wondered, when it comes to the presentation context, what do you feel is, because when it's A&E, ED, it's different, but when someone has an episode of back pain, there was some contention, especially from the private practice community, when we published the myth-busting guidance as part of a CSP working group, which became posters, which you mentioned earlier. The thing that got contended was that we'd put in there about not that present, you don't need to seek help for physio. I think it said for 2 weeks, something like that. Yeah. We're trying to offer that as reassurance, as being as if don't need to. Whereas we heard from more private practice colleagues than I expected, especially I'm sat here in my own private practice, of course, but I didn't expect the pushback that we got, and also wishes for revision, because a lot of those businesses, it sounds like, were built on people coming in within minutes. Were we too long on that time frame, or do you feel that is an appropriate angle?
I don't know. I think patients, it depends what that patient's going to do. So if that patient is going to lie in bed for those 2 weeks and not move, perhaps they do need to see someone who can give them the correct advice early on. If that patient's going to try and get moving in those 2 weeks, then, great, absolutely, it might get better. So I guess it depends on your patient, and if that patient's going to turn to A&E, maybe A&E isn't the right place for them. Maybe a private practice physio is the right person to see them, who can give the right advice at the right time. So I don't disagree, but I think there's a lot of patient factors in there, isn't there?
I think it was too blunt an instrument, really, on reflection, that poster, because we see some patients same day that we feel like what a valuable intervention that was, because they were about to take themselves to bed, and they now haven't, and they were back to work the next day, next week, maybe, depending on the severity. But there are other instances where we certainly see people too soon because they just can, and they access it, and maybe a previous patient or whatever that perceives that that's something that they want that they probably didn't need. So it's a fine line, and therefore we probably could and should err on the side of caution if they ever get tidied up, to make sure that there's appropriate caveats. I think it was sort of saying that, if things are going okay, you don't need to seek attention.
Yeah.
Whereas if they're going to take themselves to bed, be off work, and not comply with the other myth-busting posters, let's say, then that's fair.
Then they need. But also, if they, if that patient is worried about red flags, if they want you to tell them that there's nothing worrying, why aren't you the right person to do that? You're probably a better place to do that than a GP or whoever else. So I think it's patient dependent, and the posters are great. We have the posters up in ED in the waiting room and everything. So I think the posters are great.
That's great. I think that's where I think an interface for virtual as well. That's where we could really mature our models in light of having had to go more virtual. Is that's a place where it could be really strong. Is that if there are drop-ins like that, where people can, if they're about to make some poor decisions for how they behave for the next couple of weeks, something like that could really disrupt it. Whereas we know that a 45-minute initial assessment at whatever price at a private practice might well be overkill. And so having something would be a smart move. So so it's definitely a moving picture. Thanks so much for your time. Where can people find out more about you and get in touch with you if they need to?
So I'm on Twitter at Michelle Angus, and I'm at Salford Royal now. Nothing else exciting going on.
Fair enough. Well, thanks so much.
I think I probably need to mention the National Back Pain Pathway Clinical Network, which is Dermot Ferguson's the chair, but I'm the comms lead for that. So there's that you can get in touch through there, and also the Advanced Practice Physio Network for the CSP, and the education officer for that. So again, you could contact me through there.
Absolutely, and a brilliant.
Sorry, Jack,
I want to congratulate you on the event that you guys did for the APPN. Proud member of that, and you're doing fantastic work, more now than ever. I think you've really been an organisation, and you and others in the directorship of that have really stepped up in recent times, at times where we all need you. And so thank you for that. And so I do encourage people to get in touch with you via there, and to join if they haven't, if they're anywhere near advanced practice, or at least, as I mentioned earlier, the rationale and logic that applies to advanced practice should be transferable, and there's lots there to go for. So I'm pleased you mentioned that. I'd forgotten that, and certainly the resources that we've talked about will be linked to in the show notes, including all full text PDFs that we can get our hands on. So thanks again for your time, and we'll speak again soon.
Okay, thanks, Jack.
That was Michelle Angus. Many thanks to Michelle for coming on the show. Absolutely brilliant to get some of her time. I think it's something we've probably undercovered. Only when we got stuck in like that did I realise that we often talk about back pain in the sort of recalcitrant or persistent pain cases, and often these patients that might have a first episode or present with an acute low back pain episode, they're the ones that need to be managed well in order to stop that sequelae that we've sort of talked about at length. And so it was great to get stuck into that and understanding that context specificity around the circumstances of which we see them and how that might influence care. Really keen as ever to hear your thoughts. It's a contentious area, particularly when we got stuck into sort of what is it about the system that is feasible for us to be able to deliver as care, especially when it came to the sort of non-pharmaceutical side of the conversation, as well as what the role is for just pain relieving modalities generally, and if given the right context, can they have a place? It's fascinating, and I think something that I really am keen to get your thoughts on. And we have the opportunity for anyone that's got any particular feedback or wants to challenge anything to join us on Chewing It Over on the weekdays at 12:30. Now, Adam Dobson did that recently. Fantastic that he came up with some really sensible critique of the last podcast, and so he joined me to chat through that on Chewing It Over a few days later. So anyone that's got any things that they'd like to share in whatever format, they can do so, and please get in touch with us across social media. All right, thanks a lot. And all that's left to do, and I think because we forgot to get Michelle to do the cheesy sign out, that falls to me once more, because you've been listening to the Physio Matters podcast, discussing physio matters because physio matters. Bye for now.